All right, let's see everybody starting to come in now. Welcome. It's an absolutely beautiful evening here in Nashville, Tennessee. We had 75 degrees, sunshine, and it's just setting now behind me. So hope you had a beautiful fall day as well. And thanks again for joining us for this Plantrician Ed series. This is a series that we've created, and we kind of switched to a monthly format. We want to shift towards bringing you like really important educational information with a healthy zest of fun and inspiration and some stories behind the science. So I'm glad you're joining us this week. Just a few weeks ago, we hosted our 12th annual PBNHC in Anaheim, California, and it was an absolutely fantastic conference. Just to put on your radar, the 1st of September next year, we will host PBNHC in Palm Desert, and we're really going to bring in some of the luminaries and legends as well as upcoming leaders, so you don't want to miss it next year. And also on your radar too, toward the end of April, we'll be hosting our HELP conference. And this is near and dear to both Kim and I in our hearts. We really believe this is something that needs to be done. And so this is a solutions-based conference, gathering leaders from a sphere of influences in these at-risk communities to join together over the course of 2 days, talk about the science, but also to ideate and strategize meaningful solutions that we can begin implementing to assist people that are at risk, transitioning their lifestyle, and discovering true health again. And so I'm going to let Kim share a meaningful piece of information about just the power of planting trees in these neighborhoods in just a minute. So this evening, we are talking about the International Journal of Disease Reversal and Prevention. And as we were getting ready for this, I did a little walk through history and went back to some of my early emails in the latter part of 2017, when I got a call from Dan Purgis, who served as one of our board members and was a donor with seed funding for the IJDRP. I went and met him at his apartment in east part of New York there along the river. We had a conversation about starting a journal. And the conversation was to create a journal that really emphasized the power of plant-based nutrition and lifestyle to not only prevent disease, but really to reverse disease. And this became the first journal really to emphasize disease reversal. At the time, we really had no idea how to start a journal. And so we hired Dr. Lori Marbus as our first managing editor and partnered with Dr. Kim Williams as our editor-in-chief. And we navigated the challenging waterways and found a way to create a journal with the vision of removing access to both publishing and reading the journal, creating essentially a free platform that anybody anywhere in the world could access this important information about preventing, suspending, and reversing disease, and could publish their research without onerous fees to have your research reviewed. Since that time, the journal, under Kim's leadership, has grown to more than 30,000 subscribers, reaches around the world with the science of disease reversal and prevention. And so this evening, I am joined by our editor-in-chief, my dear friend, Dr. Kim Williams. I just have one slide to show Kim. Kim, I went back and looked a little bit at your history and found out that in high school, you're the team captain of your Illinois State Championship chess team. And then a few years later, you were the last University of Chicago team captain to play Division II NCAA championship tennis. I'm going to share my screen. Oh, I don't know if I have sharing capabilities, Tom. Let's see if I do. Here we go. I'm just going to pop this up real quick because this is Kim Williams then and now. And let's see if I can pull this over. So here's Kim Williams playing tennis. And you can tell us a little bit about that, Kim, but I was impressed by your quadricep there and your form. It's really incredible. And one of my favorite quotes by you there too, Kim, there are two kinds of cardiologists, vegans and those who haven't yet read the data. So I just had to bring up that fun part of your history because you have meant so much to all of us and served as the ACC president and so many illustrious positions at universities. So with that, Kim, welcome. It is an honor to have you.
Well, thank you. It's an honor to be here. And I have to reverse the shout out a little bit. I mean, so you were the Olympian, not me. I was just a local professional tennis player. That day was actually the Illinois Federal at one of our local clubs. It's a fairly big tournament on the south side of Chicago, won the singles and the mixed doubles. Total prize money about $400. But that would get me through a
You're a
couple.
professional.
That's right. Yeah. So, I did I did help myself through medical school, mostly teaching tennis, and then coached a lot of programs. So I think I did more good as a coach, honestly, than I ever did as a player. But the nice part about it is that there are two things that people could do to dramatically improve their life expectancy. One is a whole food plant-based diet that's about 9.6 years, if you believe the Adventist Health Study too. And actually, publications recently say that tennis is 9.7 years. And so I'm hoping that they're additive. And so the trick is to do both. But thank you so much for your vision. It's been I too went back and started looking back at the old journals from 5 years ago and realizing we've been through so much. We started off pretty good and had a lot of submissions, a lot of luminaries. I had this idea of conversations with legends, which really was exactly that. It sounds like a unique thing, but it popped up because I happened to be on an airplane with a legend, Neil Stone, who was our how do you say coopetition? That's the word that I made up years ago. He was at Northwestern doing prevention and was always, doing drug trials and the like. And I was talking to him about plant-based nutrition. He said, absolutely, that's part of his practice. And he said the magic words, when patients say they want drugs, but they don't want to change their diet, or the reverse, people say, I'll change my diet, but I don't want any drugs. His line was, which arm do you want me to cut off? To try to help you. I need both arms. And that was the beginning of conversations with a legend. So we basically went through that, and we've done several people, and we're going to have to corner you one day because you really are a legend for what you've done with the Plantrician Project and everything that you've done to build this whole field up in such a way that people recognize they recognize and know what they should be doing it. Now, there's a whole lot of barriers of why people don't do a whole food plant-based diet, and that's what we really have to deal with, particularly with when you start talking about help and health equity, because it's the major issue that would get those health equity issues to disappear.
Right. Yeah. And maybe while we're on that topic, would you share that piece of data that came out of your environmental health department there at Louisville? I think that was
Yeah.
so interesting with
Oh,
HSCR.
absolutely. I just a shout out to such a privilege to be chairman of medicine, probably anywhere, but particularly at the University of Louisville. And I was talking about a lot of things like first time I've been in a D1 school in basketball and women's volleyball, getting to the Final Four. I mean, there's actually real stuff going on here that I was never exposed to at University of Chicago. Wayne State was pretty good Division II football. But Rush doesn't have athletic teams at all. And so it's the first time to be around all that excitement of college sports. But the other major issue is that this university understands where it is as an urban university. And when I told a lot of people when they would interview me for some big position that I wanted to do nutrition prevention and health equity for the rest of my career, most of them would get a little skittish because they thought that they'd be losing money. Well, fact of the matter is that is in the moral fiber of University of Louisville.
Mm,
And serving the community is what it's all about. And and appropriately so, because when you look at just anybody, just put in your search engine health statistics by state, and you'll see that the Commonwealth of Kentucky is one of the worst. It's ranked 50th in cancer deaths, 49th in smoking, and all of the things that would lead to poor health are here. The diet is difficult, the obesity epidemic, which then gives you diabetes, it's all here. And so where else could I have actually taken a job? And to your point, we have people who are doing all kinds of creative things. They recognized, for example, that on the West End, where the poor, labor people, unemployed but employed in blue collar work, where industry is right there in the city, there was a lot of air pollution. And you go to the East End, and there's a huge life expectancy increase. Well, what is it? Is it wealth? Yeah, there's a lot of wealth differences, but it's also air quality. And so I live on the East End in a bunch of green space. And yeah, there's a party going on and there's a lot of wildlife, but it's deers and possums and birds and a lot of trees and grass. And it turns out that that's important. And so, yes, I am blessed to be one of, I think, about 6 department chairs that has a division of environmental medicine. And our leader, Aruni Bhatnagar, is a heavily funded investigator who really has a fantastic research enterprise. And one of the very creative things that they've done was plant trees in the poor areas where you had the poor air quality. And a publication they had about 3 or 4 weeks ago really emphasized the point that after 3 years of planting all those trees in a poorer neighborhood in the south of the west area of Louisville, you ended up with a lower C-reactive protein level of the people who volunteered to have it before and after. C-reactive protein, for those of you who have not paid much attention to it, first of all, you probably should have it measured. It is the inflammasome. So we talk about diabetes, hypertension, obesity, high cholesterol, but there's also inflammation. And so everyone should know whether or not their body has inflammation. Best way to get rid of it, whole food plant-based diet. But apparently, planting 8,000 trees will do it as well because you're improving the air quality and lowering the amount of inflammation that you're getting through your lungs. So it's all about, get biblical, but it's all about what you put in your body. What you breathe and what you eat determines how healthy you're going to be.
And it's not just the plates on your plant, but it's the plants around you as well, right?
Right.
It's all about plants.
Absolutely.
That's right. Hey, Kim, before we jump in on the journal, maybe just take 5 minutes and share with people like your journey through cardiology to becoming a cardiologist, one of the leading cardiologists in the world that advocates for plant-based nutrition and prevention, suspension, reversal of cardiovascular disease.
Well, that kind of was a weird story, Scott. I unfortunately had a single mom who worked hard, but was a smoker. And I developed a sensitivity to cigarette smoke pretty early. It's worse now than it ever was. I will get nosebleeds and cough up blood if I smell anybody smoking. And I used to think it was psychosomatic until I saw the blood. That's not psychosomatic. Okay. But I ended up with 3 pneumonias. And one of those pneumonias, I was admitted to a south side of Chicago hospital. And I knew that I wanted to get back to school, so I didn't get held back. And so I needed that penicillin, 500 milligrams orally, Q8 hours. And I was worried that I was going to get worse and they were going to start those intramuscular things that I'd had a couple times. Didn't want those. I want the oral stuff. So they weren't doing it on time. And so I started going to the nurse's station and getting my medicine, and then started going to the nurse's station, getting my medicine and my roommate's medicine. They were always behind. They were always overwhelmed in these inner city hospitals. And so I decided that was in 8th grade that I was going to be a doctor. I didn't do much about it until sort of the end of 9th grade when I realized if I really want to be a doctor, I better get some good grades. So we figured that part out. Wiggled my way out of the south side of Chicago and food insecurity and housing insecurity into University of Chicago. And it took a little bit to go from the Chicago Public Schools to U of C was a little bit of a gap, but I did well in the sort of the preliminary courses. They wouldn't let me take pre-med courses when I got there. By the time by 2nd, 3rd, and 4th year, I was doing really well. Meanwhile, I was learning to play tennis, and tennis was just a fabulous thing for me because it would calm me down. If I played 6 hours of tennis trying to make that darn tennis team, I actually ended up being able to sit and read Plato's Republic and Politics of Aristotle. And the two of them really went hand in hand. And I know you know this as an athlete, that your brain is turned on by your athletics. and I certainly was that way. So ultimately, I did get into the medical school. It was a lot easier. I mean, the medical school is tougher, but there was no big transition because I had 4 years of the life of the mind at University of Chicago. So you work really hard, ready to go into pediatrics on the south side of Chicago. And then something took over, and that was that when it was time to do EKGs, it's like I had learned it before. When it was time to listen to a heart, I knew exactly what it was. When I would listen to something, I could diagnose stuff. And as a freshman and sophomore medical student, didn't know why, but that happens. And people will gravitate to one thing. It's easier for them to learn and they enjoy it. If you can find that combination, that's what you should do. I blew it off. I'm still going to be a pediatrician on the south side of Chicago. So I did my pediatrics rotation and saw sick kids and realized that no, I don't like sick kids. I mean, they need someone who can actually absorb all of that sadness when something the pediatricians are very special people to deal with, particularly ICU. I was fine in well baby clinic, but that is a tough specialty, really tough. So I did what I think is the right thing. Once I recognized that heart disease had been the leading killer of Americans since 1918, and I had the proclivities for learning it faster than I learned anything else. Well, maybe nuclear physics. Oh yeah, and so I ended up being a nuclear cardiologist, by the way, because nuclear physics and cardiology were the two things that were easier for me to learn. So that's what I ended up doing. And as it turns out, over the years, I ran that nuclear lab at University of Chicago. Started it, ran it. Everything was going well, and then along came started getting into leadership positions. And just about when that happened, I had my cholesterol tested after my son aged out of playing junior tournaments, and I wasn't playing tennis twice a day with him. So cut down on exercise just a little bit and had my cholesterol measurement done, and my LDL cholesterol was off the charts. And that happens in the age of 40 something. It happens to people, well documented. It's genetic. And what are you going to do about it? Well, I had already heard about Dean Ornish's diet from one of my Association of Black Cardiologists colleagues, Tazewell Banks. He was always pushing plant-based nutrition for our society and for particularly for African Americans. And so I went on a plant-based diet that day, measured it a few weeks later. LDL had dropped from 170 down to 90. If I had taken a drug, I'd have been so proud. But it did it completely. And my diet was the data-driven diet. It was the American Heart Association diet, whole food, plant-based, plus some dairy, plus chicken and fish, no skin, not fried. That's not a healthy diet at all. If it has animal products, it's going to hurt you. And there are mutants on this planet, and I'm saying that in the most complimentary way, such as PCSK9 deficient people who can eat all of that stuff. And maybe they'll get some inflammation, but they're not going to get a high LDL cholesterol. I was not one of those people. And I wouldn't be sitting here talking to you more than likely, African-American male over 60, if my LDL had not been controlled with diet or some kind of intervention. So that really steered me toward nutritional cardiology. And then the world opened up because I realized that my nuclear lab was all about diagnosing a disease that is already present so that I could give the information to someone who could then mop up the floor. So I was measuring how much water was accumulating in the floor and the quality of that water. Why not turn off the faucet? And so that's really where I've started. I mean, still love cardiac imaging. I still love nuclear physics. But fact of the matter is we can do so much better by doing preventive cardiology. We need to do a lot more attention to prevention. And if we do, our whole country will benefit.
And what year was that you made that transition?
That was
I know
2003. I remember
2003.
it
Okay.
was American College of Cardiology meeting back when you would do the stand in line, get your finger stick. And I was so hard-headed when I saw that LDL had gone from like 110 a couple years earlier to 170. I went to their competitor's booth and it was 169. So then I fasted all night, came back to the third company and it was 169. Said, maybe it's real. I better do something.
Oh, that's great. Thank you for sharing that story, Kim. And for the last 21 years, then you have done amazing things in cardiology, 2015 ACC president, and the first, and still, I think to this date, right, ACC president that has advocated for nutritional intervention as a primary intervention for cardiovascular disease.
Very true. There have been people who have been predominantly plant-based that I know of, and then some who are completely opposite. And my magic question that I give patients and colleagues is there any food that tastes better than your health? And one of the presidents after me said, "Yeah, bacon," and I was just crushed. So.
Oh, that's great. Let's pivot to the journal. And for all of you that are following us, and thanks for joining us, more than 200 people on with us now. Thank you. And so if you have questions down at the bottom, you can just ask in the Q&A bubble there under the more icon, and we'll get to your questions as we go. So Kim, I'm just curious, as we're going back, and you and I both did kind of a walkthrough history with the journal back to 2017 and 18.
Mhm.
I was just curious to ask you, like, what was it about the journal that made you say yes when I called you?
Oh,
You're
it's
so busy and
Scott, it was who you are. Because if you asked me, do you want to run XYZ, I probably would have said yes, just because of what you've been able to accomplish and the education that you put out there, the idea, which is exactly what we need in this country. People who are really concerned about health, not just using this as a business, but realizing that these are lives. And, every time someone has a heart attack, they can get a stent. It's not so bad. But when they have a stroke, it takes their entire family down. How many days of work is their daughter or their brother or somebody going to miss? The whole idea of vertical wealth, well, it's vertical health. And so once you start having a more healthy approach, it affects the people around you. And that's what you've been doing. So yeah, I'm very glad that you reached out to me. I had some journal experience as the editor of the Urban Digest of Cardiology, which was the Association of Black Cardiologists a few years earlier. Without sponsorship, it didn't do so well. But I've always had a penchant for statistics. I talked about nuclear physics and cardiology, but yeah, I'm a closet statistician. And so the idea of analyzing a paper, testing a test, and studying a study is something that we all should do better. And I've always tried to do that. Having an opportunity to try to affect the medical literature in a meaningful way and get people to focus on prevention is great. Now, I have to admit, when you get reviewed by PubMed, they want to know how many articles have you rejected. And we do reject some, but we actually try not to have rejection be the final outcome. I will sit for hours with a manuscript, trying to improve that manuscript, get the study design better, get them to express themselves better, some English editing, sure, but more importantly, to make sure that they have quoted all of the right literature. It does take a lot of studying and pulling out stuff and then sending it back to the authors and say, if you do these 10 things, then I'll send it out for review. But by the time we send it out for review, it should be cleaned up quite a bit. And so that is why our rejection rate isn't so low, because we really do everything we can to get someone's out there trying to get a point across. And I know that rejections are how you get your journal to be exclusive and famous. I don't buy that at all. I think what we should be doing is transmitting information to people that's going to help them in their practice or in their lives. And we can't do that if we just say, this really wasn't good enough. We're sorry. You might try another journal.
And that's your gift as a teacher. You're teaching people that are publishing how to do it better along the way as well. I don't know of any other journal that actually does this as well as we do, coaching people that are submitting on how to improve their manuscript.
Exactly.
It's really a gift. And for people that aren't aware of that is something that Kim, like he said, and I know this, he spends hours working with the authors to improve their publications. And that is incredibly unique and an amazing opportunity to draw on your years of experience. So I appreciate that, Kim. And maybe share with us too, I was curious about, when you first took on your role as the editor-in-chief of a journal, what was your vision then? And maybe how has that changed now to your vision for the next, 7 to 10 years of the journal?
So, it is, we do have aspirations to be on PubMed, not just Google. And, it's easy to find our articles, but we want it to be, have an impact factor and H-index and all those sorts of things so that people will feel like they're getting a whole lot of credit, not just distribution. And so we have to keep working on that. It takes a while to get into PubMed, and we will keep pursuing that. But so that's sort of at the front of brain. But moreover, it's about making sure that people are putting in quality material and that we are publishing the highest quality that we can. And it does take a lot of work. A big shout out to all the editorial staff with our publisher and our managing editor, Claire Shivers. She's, been a tremendous resource taking this job over a few months ago. And, we had some wonderful editors before as well, managing editors and our associate editors, because I do try to, every once in a while I put in an article and it has to be reviewed completely hands off by me. And we have some wonderful people who have been stepped into the lead editor roles for that. So when I look back at the journal, we started off with a lot of controversies, nuts and seeds and oils, and are they healthy? And we try to put data into the arguments instead of just people, going back and forth at each other. And a lot of it was, sort of people who were on the internet sort of creating a disturbance about it. And as they say, shedding a lot more heat than light. So why not actually go through the literature and actually make sure that we're evidence-based? And I think we were able to accomplish that. And so I don't think we have as much in the way. I mean, you have differences of opinion, but I think everybody understands that we really should be as evidence-based. And I know, I don't know if you're going to remember this, Scott, but I told you if I take over as editor, and I'm not sure you're impressed with this, but I said, if somebody, and I usually don't use brand names, but if somebody does a randomized prospective trial with long-term outcomes and it shows that Pennzoil 10W30 is going to remove peripheral artery disease, then we're going to publish it. It's not about plants, okay? And we're going to publish the real science. Of course, that hasn't happened. We pretty much are a plant-based journal, and we've stuck with that because that's where the data is. And there's a massive number of things that have come up over diseases that have come through. And yeah, we get a lot of diabetes and we get a lot of obesity, okay? But there are such a wide variety of diseases that are affected by nutrition, and the opposite, that is, nutrition by, plant-based nutrition can cure it or remove it or make it better, and eating a poor diet accelerates it or causes it. And the journal is full of that. I mean, so going back and we're looking at Fuchs corneal dystrophy and retinopathy and for diabetes. And we have so many articles that if people would just focus on what's in there and change the diet, and we have a lot of articles on how to change the diet, how to change your diet for yourself, how to change your diet for your family, how to change your diet for your institution. Okay. And so that that whole thing of someone coming having a heart attack because of what they ate and going to the cath lab and getting a stent put in, and they get it that door to balloon time less than 90 minutes. That means that the wall motion is going to be good. The function of the heart is going to be good. And then the next morning they're being fed bacon and eggs in the CCU. And so we have to keep pushing the envelope and getting people to understand that nutrition is what caused it in the first place, get the patient to understand that, but change them inside the institution as well as out.
Yeah, great. Thank you. And you're exactly right. I mean, the journal is a tremendously rich source of scientific information that we've accumulated over the last 6 years that it's been published, um, and serves as a wonderful resource for Plantrician University, as we've plugged that in and kind of cross-pollinating Plantrician University with all the science that's in the journal, and then asking our residents and our medical school students to begin their publishing careers, starting with IJDRP. It's a beautiful marriage between those two.
I'm glad you mentioned that. And so I think the people who are reluctant to put it in until it gets listed in PubMed are the assistant professors trying to go to associate and the associate trying to go to full professor. But for the residents trying to become a fellow or fellow trying to get on faculty, it's beautiful because they're going to get some coaching and some counseling on the article that's going to enhance their skill set for future publications. And for the full professors, they're not going to be promoted again. Put something out there. And we do have a lot of people on both ends of the spectrum submitting to the journal.
Yeah, that is great. Thank you, Kim. We have a couple of questions. I'm going to just take one and we'll chip away at these. So this is from Brian. Brian asks, what, if any, is the role of ceramides in the development of cardiovascular disease? And are there any clinical targets, treatment, or prospective treatments on the table with regard to ceramides?
So this is a journal thing. So I have to tell you, we don't have any articles on ceramides. What I do know is that we were working with one of the investigators and I don't like brand names, but Cleveland Heart Labs that I think they got bought by Quest. So I don't know how much they pursued it. We were trying to do a plant-based intervention. We did one on the south side of Chicago. It was Boston Heart, that their big competitor, who helped us with that. So next time we're going to go with those folks in Cleveland, and they were absolutely convinced that it's a huge risk factor that's being missed and never measured. And so they were hoping to take our population before and after plant-based nutrition and compare them. Now, that would just be a start with the ceramide story. They also had MDMA and several other molecules that they thought were risk factors that were worthy of investigation. But I'm just going to say, the key for any risk factor is to show that it correlates with disease, yes, but that changing it actually means something. Changing it could change the outcome. That's what happened with the HDL, high density lipoprotein. Everybody heard the HDL is happy cholesterol, it's good for you. And then we find out that raising it more and more increases mortality. And we never did get the data that changing the HDL would change good solid data that it would actually change the outcome. So that's the challenge for ceramides.
Great, thank you. And while since you mentioned the oils, Mike asks, are any oils healthy to consume?
So if you listen to the Caldwell Esselstyn and there's a handful, I know John McDougall passed away recently, wonderful guy, wonderful investigator. Um, and T. Colin Campbell, you've got a bunch of people who are in the no oil camp, and then you have the Joel Furmans who are saying that healthy oils would be ones that have a small amount of saturated fat relative to the polyunsaturated fat and monounsaturated fat, both of which have been shown to lower LDL cholesterol and lower mortality, that high bar that I was setting. And so you do have, and interestingly enough, it's not just about cholesterol. Neil Barnard published a randomized trial and saw dramatic, that was Mediterranean diet versus vegan, and had a dramatic reduction in blood pressure because of the polyphenols in the extra virgin olive oil. And so there are some healthy principles of healthy fats, vegetable fats that are low in saturated fat. Now, remember, whether it's saturated, trans, poly, or mono, it's still 9 calories per gram. That's a massive amount of calories. So with most of our people, particularly in Kentucky, struggling with weight, no oil is something I pull out. I send them Caldwell Esselstyn and stuff all the time. And if they're a thin person with a high LDL like myself, sure, healthy oils that will lower your LDL would be great. But for a lot of our population, no oil is a better approach because of the calories.
Right. Yeah, 120 calories per tablespoon. That's right. And I think Monica Agrawal just published a very interesting study as well. Um, I just pulled it up. Recipe for Heart Health, a randomized crossover trial on cardiometabolic effects of extra virgin olive oil within a whole food plant-based vegan diet. I don't know if you've seen that one, but
Did, yeah.
that was a good one as well.
Well done.
So yeah, some interesting studies on oil. So that was a great question. Thank you, Mike. I wanted you to share, because I think it's such a poignant story about your experience at Rush when you began to recruit more cardiologists to plant-based nutrition, and we're seeing, all of these changes within the system, and the system started to feel the financial strain of the whole food plant-based diet, preventing and suspending cardiovascular disease as well as suspending procedures, right? And you had some interesting conversations with the powers that be. So
They
would you
were very
more
interesting
about-
conversations, no question about it. But let me just say the difficulty with the finances at Rush was less about the plant-based nutrition and more about our going to the inner city and doing the ASCVD risk calculator. If anybody doesn't have it, you can just Google it and pull it down and put it on your phone. You do a finger stick cholesterol, blood pressure, and find out who's vulnerable, who has a 10-year risk of heart attack, stroke, and death of more than 7.5%, then you get them in. Well, if we go to the south side and the west side of Chicago, you're going to get a lot of poor people. And the uninsured and underinsured, they were never appreciated. University of Chicago really didn't want them back in the day. Maybe they do now. Wayne State wanted them but couldn't afford it because the state legislature just was never giving Wayne State enough money to be able to take care of all the population. And Rush, they put up with it because they knew it was the right thing to do, but they put some limits on it. And they had an administrator who would go through and, kind of not wallet biopsy, but at least check the insurance before we get people in. At Louisville, it's completely welcome. And we would give our last personal dime to take care of a poor person who has cardiovascular risk. So that was one major issue, is screening people. Then my other issue was plant-based nutrition and the fact that people were coming to me specifically, and a lot of them were actually sent by Essie from Cleveland over to Chicago. But they were coming to try to avoid high-risk stenting or bypass surgery, particularly bypass surgery. And the fact of the matter is that was the perception that we were able to, forks over knives, you eat the right stuff with your fork and you don't undergo the knife. But in actual fact, all it did was bring a lot of people who ended up with their procedure at Rush. So the whole thing was completely not true. It just attracted a population that they weren't otherwise going to see. But the conversations were very real. I did have a person in leadership. I won't say his name because he might be listening, but I doubt it he's listening. But actually tell me that the junior people in the cath lab did not appreciate having a vegan chief because they felt like it was going to inhibit their business. Now I had hired all those people, so I went and checked with them. They didn't say that at all. They said, no, seems to me I'm doing people coming from Cleveland and everywhere else because of your plant-based nutrition. And that's because, people, I just to be really clear, I don't view anything that we do in cardiology as wrong. Is it necessary? If everybody would go on a whole food plant-based diet from let's say arbitrary age 10 and up, we're really not going to have this problem. But once you have the problem, you need all hands on deck. And so that was the Neil Stone, that's volume 1, number 2. Which arm do you want me to cut off? Okay. To help you. Preventive diet or preventive medication, you need them both when you have critical coronary disease and high risk. And it's taken a while, I think, for our plant-based nutrition folks to adopt that, hey, statins, revascularization, sometimes they're necessary. On the other hand, you have so many doctors who are still telling patients that, oh, your diet doesn't matter, you have critical disease, you need to go and have your bypass surgery. So I'm still seeing them. They look me up, they see your program, and they come to Louisville. Had a gentleman drive from Maryland today, exactly for the same thing. And, I'm happy to see people, but I want them to know that, cardiology and the procedures are doing well. You don't need them if you could go in a time machine and get rid of this plaque and don't develop it. But every animal carcass, hate to be gross in front of 250 people, it looks like, but every animal carcass that you consume leaves a piece of itself, microscopically as plaque, and we need to just stop that.
Yeah, thank you for sharing that, Kim. And along those same lines, we have a question, and I'll just summarize. Essentially, this gentleman has, outstanding lab work, and he's asking the question: do you think a CT scan, a calcium CT score, is helpful as a screening test? And maybe generally, what do you think of that as a screening test?
So I'll just be honest with you. See, the CT coronary calcium score, if you did it based on the things that you find out divided by the price, it is the best test in the history of cardiology. And I'm saying that because I get to find out if someone has calcified valves, a dilated aorta. I mean, so that gentleman who drove in, sure enough, he had a calcium score and a dilated aorta. If we don't follow that up, he ends up with a ruptured aneurysm. And so it's such a powerful test because it actually does so many things. Okay. Now, funny part about it is that it is one of those areas of healthcare disparities because only 3 states right now, we have 47 to go, 3 states actually insist that insurance pays for it. And so there's a publication, if anybody's interested in it, myself and Michelle Ikram, is your calcium score, is it scored or is it ignored? And the idea was that I was trying to convince Rush to drop the price. University of Cleveland did it, and the number of minorities who came in and got the test dramatically increased. Now, the interesting thing is that insurance will pay for everything else. So once you do the coronary calcium, you find some horrific score, they'll pay for a stress test. Okay. They'll pay for a vascular surgeon to put a stent in the dilated aorta. Okay. They'll pay for all the consequences, but they won't pay for that initial thing. It's cash payment only. And so we were charging $100 at Rush, and I was trying to convince them to do what Advocate had done in the area, which was 49. So we did this big project. I had my research assistant, Michelle Ikram, who's now a cardiology fellow, go through every institution in the Chicagoland area and get the price. And I found out Rush was not overcharging. The average was $200. Okay. It's just Advocate was an outlier at $49. And so, but then when she showed me the data, I said, wait a minute. I told you the story about me having all the pneumonias. I went to pretty much every one of those hospitals because we were really poor and they would never renew the lease. So I went to 8 different grammar schools. So I went to like 5 different hospitals when I was sick. And they were all missing. Michelle, how did you miss the hospitals where I grew up? She said, they don't offer it. I was stunned. So we did publish that. And so we actually did a statistical analysis. In order to have your hospital have a calcium score available, you have to have a certain income, a low number of unemployed, a low number of people who with a low education, and a lower number of African Americans. And if you have all those things, your hospital has coronary calcium scoring available. So anyway, I'm glad the person asked about it. And I did mention the risk score, the ASCVD risk score. Please download it. You got Thanksgiving coming up. You go to Uncle Joe and say, how old are you now? And what was your last cholesterol? And what was your last blood pressure? And when did you quit smoking? You put all that stuff in the calculator. And if it's above 7.5% and they haven't had any testing, a coronary calcium score is a good place to start. That's in our 2019 Primary Prevention American Heart Association guidelines.
Great. Thank you, Kim. Thank you. Next question, and this will be an interesting question for you to answer. Trevor asks, how would you explain the following? When both parents had high cholesterol their entire lives, no meds, non-smokers, exercised regularly, no heart disease, Mediterranean diet, and lived to 95.
Okay, so yes, there are outliers. And I can tell you, you could talk about allosteric load. Were they living a life that was less stressed than most people? And fact is, when you say high cholesterol, you need to know what that really means. LDL cholesterol that was elevated, it just becomes unlikely, not impossible, just unlikely. And so a lot of people will still want to know what their cholesterol is, and we really should be focusing on triglyceride and LDL cholesterol. So that would be the first question is, how high were those numbers? And if total cholesterol is high, but those numbers are good, then that's good, and you can live to 95. Now, of course, we're viewing that as 5 years short. Dan Boitner, and the blue zones, we want everybody to live to 100. And so, but if they live to 95 without any cardiovascular disease, you could call that a win.
That's a big win. Absolutely. Especially with quality of life.
Absolutely.
Next question for you, Kim. In addition to whole food plant-based diet, how else can someone lower their HSCRP?
So exercise lowers it. Mindfulness, trees, as we found out.
That's right.
But I do want to emphasize that we have there are medications. I have a good friend, Paul Ritker at Harvard, who actually patented C-reactive protein. And people say, oh, he's doing all this research because he gets a nickel for every time somebody. Well, first of all, Harvard takes half the money, and the other half he gives to a inner city tennis facility. He's on the board of the Sportsman's Club. It was started years ago. When I was a tennis pro, I actually went and did a demo for them in the late 70s, and then find out decades later that my good friend Paul Ritker has been supporting those kids. Tennis and education go together. You get them on the court, and then he has retired teachers who tutor them, and their incidence of going to college from these inner city kids is almost 100%.
Wow.
So anyway, that's the CRP story that I really like to tell. But he has pursued this very well. He's done canakinumab, methotrexate. He was a lot of the data behind going to the FDA and getting colchicine, an indication to lower the inflammasome. That was Paul Ritker's work. What he basically showed is that if you have your LDL less than 70 and you're otherwise controlled, but your inflammation is high, you still have a very high risk, double the risk of a person who has low LDL and low C-reactive protein of having heart attack, stroke, or death. And so we need to take the inflammation very seriously, exercise, diet, and medication if you have to. But remember that statins dramatically lower C-reactive protein. There are some medications that are largely ignored and shouldn't be.
Yeah, super. Thank you, Kim. We've got a growing list of questions, so I'm just going to keep rolling here. Do you believe a plant-based diet is beneficial for those with congenital heart conditions?
So interestingly enough, congenital heart disease is a major problem that's been progressively better and better. If you haven't seen the one about the movies about Blaylock and Taussig and the fact that they have progressively gotten surgical techniques. Some are open, some of them can be done so-called percutaneously, that is without opening the chest. And we've gotten to the point where you can fix a lot of these congenital issues and keep people alive for decades. And so instead of being a death sentence before age 10, they're living into their 50s easily. And guess what? They're developing American diseases. And so the congenital part that's most important is not on top of everything else that they've been through their entire life, developing coronary heart disease, leading killer of Americans since 1918. And that's because of our diet.
Yeah, super. Thank you, Kim. Yeah, there's always benefit in adding more plants, in supporting the system, no matter what you have congenitally or genetically. Supporting the system is always advantageous.
Yep, absolutely.
So here's a good one to dive in on, and we can go a little deeper in this question. So this comes from David. He says, I'm a plant-based physician working with doctors, nutritionists who are now pushing the carnivore diet to reverse metabolic diseases and lower inflammation. They claim that meat is the most nutrient-dense food and cite cases of individuals who have lowered their blood pressure, fasting insulin levels, cholesterol, and inflammatory markers. This seems to be the opposite of what I've learned from the plant-based medicine world. Do you have an opinion?
First of all, I don't have any opinions. It's all data. And I would say 3 out of 4. If you wouldn't mind, Googling the fourth one, inflammation, and show me any animal product that lowered inflammation, I'd be interested in it, just because my understanding is that there is no such thing. But the other 3 are absolutely true. Okay, that is a keto diet, high in meat, high in fat, avoiding all carbohydrates, will drop your weight, which drops your insulin levels, which drops your blood pressure. Now, if you look at the wonderful article by Carol Kirkpatrick, who I was actually debating, and then she wrote an article taking my side, and she did that for the Journal of Lipidology. It increases inflammation and increases LDL cholesterol. And that's why I encourage, the plant-based doctor who's dealing with all the carnivores, get those carnivore doctors to just Google the words keto diet mortality, 2 words. I guess that's 3. Keto diet mortality. Okay. And what they will see is multiple articles, particularly the one by Sarah Seidelman, which actually says there's a linear increase. The more keto you are, the higher your mortality. And before her article, there were like 8 different articles. And one of them said it was a 71% increase in mortality. One of them said it was a 13%. And all the other ones were, somewhere in between. Well, that's because they were varying levels of ketosis or low carb. And the more low carb you are, the more meat you're eating, the lower, sure, you can reverse your weight, you reverse then your insulin level will fall, but you're going to die. And that's really not good.
Yeah, great. Thank you, Kim. Those are great resources. And I see that Jill's posting those in the chat. So if you want to link to some of those articles,
oh, great.
There. So that's fantastic. And I know this is a really big issue. There's so many carnivore diet, ketogenic physicians. Even in the clinic where I work, some of the physicians, advocate for ketogenic diets and cite short-term studies that highlight, lower insulin levels, better A1C levels, and ignore, like you said, long-term mortality and other issues associated with that. So
absolutely.
Always in context. Next question. Stress and its role in high cholesterol seems to get less attention. I'm wondering if anyone is looking at the possibility of Lp(a) gene being more prevalent in patients with high stress levels, and whether or not it might not be a gene turned on in a high stress population and pass through these families. Kind of an epigenetic, I think, relationship, it sounds like they're asking about, Kim.
That sounds like someone who ought to write a review article for the IJDRP. So what they're getting at is the fact that African Americans have higher Lp(a) levels than the rest of the population, and higher mortality and higher blood pressure, more diabetes, more obesity, but usually not higher LDL cholesterol levels. And the fact is the allostatic load, the stress that people are under, the cortisol levels, the catecholamine levels that they put out because they're facing, racism every day, or high stress in their neighborhood, or high stress in their home, poverty, and, food insecurity, housing insecurity. All of those do add up to worse mindfulness And those stress hormones, I hate to do this, but I got to be honest, been really impressed when you talk about stress hormones by the recent literature about how animals are slaughtered. And I encourage everybody to become familiar with that. So the cortisol, adrenaline, noradrenaline, dopamine levels all go up when the animal is being prepared for market. They're scared. They're sentient beings, and fact of the matter is, it's really tough on them. So what this literature is saying is that, unlike what I would have thought, gastric acid is going to destroy all those hormones, and it goes everything that you eat, the nutrients go to your liver. Therefore, your liver would take care of it. Apparently, it's not true. And you are eating their fear, as one vegan guru said. And so that is on top of the effects of your own hormones from racism and from stress and poverty. So you put all that together, and you have increased risk. Now, what I'm hoping that that person will do, it's related to LP little a, just by measuring it before and after. Be nice to have the LP little a, before and after trees, before and after. We've actually measured it on the south side of Chicago with a whole food plant-based diet. And that study did show a 10% drop in LP little a. Now, you'd like to have it an 80% drop, and there are 4 drugs that are in FDA trials right now to lower LP little a. In preliminary trials, it works, but the question is, as always, does lowering your LP little a lower your risk? Or is it just a marker that you can change it, but it's not going to change what happens to the person? Because, we think it's going to improve things like HDL. We had a mechanism, reverse cholesterol transport. It's going to pull your HDL, and we had HDL Milano that actually showed reversal of plaque, but improving HDL didn't actually improve any outcomes. So we have to await that data. They'll get FDA approved, and then the post-market studies will actually show whether or not it helps. So we're all very interested in LP little a because of the healthcare disparity that we have, that we think may be part of it, but the story is yet to be written.
That's great. Thank you, Kim. Next question is, and I'll just summarize, can you talk just a little bit about algae supplements and the concern that some higher doses cause heart issues for some? And how should we assess this and the safety of dosing and kind of counterbalancing the amount that might be recommended for brain health?
So I had just a few minutes ago I said I never have any opinions, never use the absolutes. I do have a concern. That's not an opinion, it's a concern. I would refer everyone to March 7th, New England Journal of Medicine, microplastics and nanoplastics. Okay. That I'm 5 years of academic cardiology. I've never seen anything that I can think of that had a 453% increase in heart attack, stroke, and death. And that's what you have if you have plaque with demonstrable polyvinyl chloride and plastics, microplastics and nanoplastics. It turns out that we have polluted our oceans to the point where seafood is the #1 source of microplastics. And there's, plastic bottles and plastic food containers, and the water that's unfiltered has plastics. And plants have plastics because they're watered with water that has plastics. But the sea, anything that lived in the sea, before I would take it, I would want to know that somebody's done an assay and shown that particular thing, in this case, algae, does not have plastic in it. Now, this is 7-month-old data, and I don't know that we are really going to have a lot of data on this for everything that lived in the sea, but I raised it as a concern. So was I taking an algae supplement? Sure, I was. And did I stop that day? Absolutely. Okay. So where to get the omega-3s? So hemp seeds, chia seeds, walnuts, plenty of omega-3s. And people say that, it's alpha linoleic acid and you're going to metabolize it slowly. Um, I think the jury is still out on that. I think people who do those nuts and seeds do actually pretty well. And so I don't know that we absolutely have to rely on things that are from polluted oceans.
That's great. And one more time when that statistic came at the beginning there, the 435%.
Yeah, it was a hazard ratio of 4.53.
Yeah,
I,
wow.
I saw it looks like your staff put it in the chat, a New England
Yeah.
Journal of Medicine article, but anyone can just put in their search engine, microplastic NEJM, March 7th, 2024.
Yeah, it's a very important trend to follow for sure, especially in having that data ready to share with patients that are consuming fish, thinking they're doing something good for their health.
Yeah. The funny part about that story is that Walter Willett's group, the Harvard Chan School of Public Health, they were actually okay with a Mediterranean diet to some degree, but plant forward, and plant exclusive was best in all their data, as it was in Adventist Health. Adventist Health said that pesco-vegetarians didn't do very well, okay, compared to the completely vegan people. Interestingly enough, that Walter Willett study of red meat is so bad for you, what can you replace it with that will lower your mortality? And the answer was everything except fish. It didn't reach statistical significance, but the hazard ratio was 1.06. Soy protein was like hazard ratio of 0.62. I mean, it was a 38% decrease in mortality if you take all your red meat and substitute it with soy. But legumes, beans, all of them did good. Poultry even did okay. As you would expect, it's not red meat. It doesn't give you the TMAO level. The cholesterol is the same, but the inflammation may be less, and the TMAO level is lower. Therefore, and the fish, you thought it was okay, but that hazard ratio was on the wrong side. It was the only thing that was on the wrong side of the 1.0, meaning that fish in their data was a hair more dangerous. Didn't reach statistical significance, so they didn't make a bunch out of it. But it hit me when I saw the microplastic stuff that fish have become dangerous. And so, if you had fish from 30 years ago, maybe that was okay. It's not as good as plants, clearly not as good as plants, but the increased mortality was small in all of their studies. But that is Nurses Health and health professional follow-up, which is mostly doctors and nurses. That one showed a 6% increase or increase in and a decrease in mortality of 6% if you change from fish to vegetable protein. And that was a relatively small change as opposed to like a 31% improvement if you got rid of processed meat, which was just the worst of everything. It was worse than eggs. Eggs were worse than red meat. Red meat was worse than poultry, fish, and dairy. Well, it turns out that was from 30 years ago when those people signed up for the study. It's different now.
Yes, the world has certainly changed. Next question, what are your thoughts on the ability to reverse calcifications in someone already following a whole food plant-based diet? And does vitamin K supplements serve any role in this setting?
Okay, so let me answer the second part first. It's not vitamin K, it's K2 and K2 natto. You can get natto, it's natural, it's over the counter. And I'm waiting for any study that shows more than what they say it does. It can remove calcium from plaque. So can EDTA. Now, the question is, does that improve any outcomes? In theory, no, it won't, because calcium is your friend. And I know it's really frustrating to people to get a calcium score and they want to see it go away. No, that's not what happens. You take the calcified plaque is the stable plaque that will never give you a heart attack. Okay. And the calcium score will go up if you don't control yourself. If your blood pressure is high, your cholesterol is high, your calcium score will go up because you're accumulating and trying to desperately to heal the plaque that you're accumulating. On the other hand, if you do everything right, all the plaque the lipid-laden plaque starts to regress, and part of the regression is reabsorption, and part of it is the healing where it becomes fibrous connective tissue and then calcifies. So guess what? If you do everything right, your calcium, including statins, your calcium score goes up. So repeating the calcium score, we don't do it very often. Why do we ever do it if we know that it's going to go up if it's bad and going to go up if it's good? Well, I tend not to do it in people who have controlled LDL cholesterol and they're on a statin and a whole food plant-based diet and exercise program. And but when are we curious about it? Is the issue of aspirin, and I should just say up front, aspirin is now not the favorite anymore. We have three so-called P2Y12 inhibitors, Brilinta, Prasugrel, and Clopidogrel, otherwise known as Plavix. Plavix is the least expensive. That becomes our aspirin. Why? Aspirin gives intracranial hemorrhage and GI bleeding, and you don't see that as much with the other three, and they're more effective at preventing heart attacks. Therefore, but my point was that if you have a little bit of coronary calcium, that is a score between 1 and 100, that means that you really should be on a statin and a whole food plant-based diet, doing your exercise program, doing everything you can to get your LDL cholesterol less than 55. Great. If it's more than 100, you probably should be on an antiplatelet drug. And we have switched. We should switch based on the Panther trial, if someone wants to look that up. You would switch from aspirin to one of the newer agents. If it's more than 300, that's where our committee, I said no opinions, but this was the committee, us people sitting around the table writing those prevention guidelines. If it's more than 300 or so, we probably should do further testing. Maybe it's a CT angiogram, maybe it's a stress test. It's just a lot of plaque. And I tend to do more of that kind of testing, follow-up testing, if it's in the upper portion of the coronary arteries, that's the left main, or the one that they misogynously call the widowmaker, because as if it didn't happen to women, it really does. So the top port, a proximal portion, as it's called, of the left anterior descending, the biggest of the three arteries. So if you have those two involved, even if the score is 200, I'm probably going to do a stress test or some kind of follow-up to make sure there isn't tight narrowing there that would benefit from a stent.
Great. Thank you, Kim. We have a follow-up question on the oil,
Mhm.
kind of setting aside the calorie density and just talking more about heart disease and stroke risk. And the question is, what is the evidence on nitric oxide reducing risk and the effects of the polyphenols on like endothelial cells? Would it be better off avoiding all oils completely, or is it better to have a certain amount of oil every day with the polyphenols to support the endothelium?
So I'm still stuck on the weight because that's where I'm living.
Yeah.
Okay. And so I'm assuming that person is, I heard we were talking about before, and it's talking about a thin person, no central obesity, okay, no high insulin levels, no prediabetes or diabetes. And in that situation, a person who's exercising those calories off, improving with nitric oxide or polyphenols, vasodilators, lowering blood pressure, those really can preserve the vasculature. Everybody's talking about Alzheimer's disease, and Dean Ornish fortunately published this, and this is one of the mechanisms where the Ornish diet decreased Alzheimer's disease. And all those drugs that are FDA approved, they're not approved to decrease Alzheimer's. They're approved to decrease the worsening of cognitive function. He actually showed improvement in cognitive function with a whole food plant-based diet. And a lot of that is blood pressure control. If the blood pressure stays normal to low, you're preserving your brain. You're not developing heart failure. You're not shearing off arteries with that calcified plaque we were talking about. And so you're cardiovascularly and cerebrovascularly more safe. So no problem with nitric oxide or polyphenols if you're taking oils in a situation where you're not overweight.
And heating those at a high heat can make them oxidative. So, the heat is also an issue with oil.
So I actually, someone challenged me to look that up. And that's the best part of having all these artificial and or augmented, I mean, they're really cool. You put in a question like that, and uh, what it told me is that that was a myth, that it doesn't. And I've been saying that for decades. But you know what? There was a lot of things that we said in cardiology that were not exactly evidence-based. So that's it's and part of it is that there was old data. Someone published that. Someone convinced you and I that you were going to
Yeah.
oxidize that, and if it's particularly if you got to the smoke point. But uh, everything moves on. It's amazing, isn't it?
But that's science, right? That's why we have a journal. That's
Yep,
why we have these conversations,
that's
because
right.
we're always evolving and learning and asking curious questions and testing the hypothesis.
Right.
That's the fun aspect. It's, and never to marry anything or hold anything too tightly.
Absolutely.
All right, so we have just a few more questions and then we'll let you go, Kim. Maybe we'll do two more here. With regards to heart disease, are smartwatches useful even when someone's on a whole food plant-based diet, or do they just promote anxiety?
I'm sorry. I missed.
Yeah, are smartwatches useful
Yes.
even when someone's on a whole food plant-based diet, or do they just promote anxiety?
Wow, that's a good question, and
Yeah,
I hadn't thought of it. I that would be a wonderful study. Yes, there are people where our guidelines, starting in 2017, hypertension guidelines, de-emphasized office blood pressures and said we need to do them at home because of two things. One is office or white coat hypertension. Everybody had heard of that. What they hadn't heard of is one of our major health equity issues, which is masked hypertension. Imagine a lady, 80 years old, living in my old neighborhood. There's some gangs, she hears some junks. So, we were all taught when you hear the gunshots, you get in the bathtub. And the fact of this, she's living there by herself because the man in the African American community, the men are gone. Um, with the lower life expectancy that we have as African American men. And so living by herself and with anxiety at home. And then she comes to Rush for from the south side of Chicago. And she's sitting in my office and I'm 45 minutes behind because I'm talking to too many people about counseling their diet. And she's in a comfortable place where everybody's being nice to her. And the blood pressure can literally be 30 millimeters lower in my office than it is at home. So for those two reasons, masked hypertension and office hypertension, we have tried to get people to do home blood pressures because they correlate with outcomes. Now, what the person is asking, though, is what about the person who gets upset at their readings and then the readings get higher and higher and higher? So my answer has been do it until you're bored. I mean, so if you do the first one and then you can feel your heart rate going up because you don't like the number, and you do it a second time and it's higher than a third, keep doing it. Watch, a television program, sit, relax, mindfulness, read some scripture, do some prayer. Do it over and over again until you're bored to tears. And that tends to get over the anxiety, just repeating it over and over again. And are there people who, when they do it 17 times, they're worse off than they were the 16th? Very rarely. Most people get bored and the boredom helps the blood pressure go back to normal. So that's really only talking about the blood pressure because we have data on that. I don't have, if in terms of an Aura ring or something like that, I can tell you that smart watches don't do blood pressure as well necessarily. They do heart rate pretty well. The number of people who have false positive for atrial fibrillation was very high, but the false negatives are very low. So that makes it worth it because nobody wants to have a stroke from unrecognized atrial fibrillation. But the adding something that will actually that you could wear to bed and measure sleep. I have to say that sleep is one of the things that we largely ignored. And for those of you who had heard, American Heart Association prevention life simple 7. Well, there's 8. They changed it a year and a half ago. to an eighth one, and that was adding sleep. So we do need to know if people have sleep disordered breathing, if they're unable to sleep for any reason that increases the cardiac death rate, increases atrial fibrillation, increases blood pressure.
Great. Thank you, Kim. Last question, and then I have a couple questions for you. So the question is, what is the current data concerning the use of colchicine in coronary disease to decrease inflammation?
Yeah, that was the Col believe it was the Colcott study. They actually did show a decrease in cardiac events that was substantial. Paul Ricker was, I believe he was the first author and the major person, proponent of it. And that's why the FDA approved it for reduction of cardiovascular events. And the mechanism is to lower the C-reactive protein. If you lower the amount of inflammation, your plaque burden, whatever it is going to have less volcanic activity. People don't realize that a plaque is basically a tiny little volcano inside your artery. And if you eat that keto diet, okay, and you upset that plaque, then it pops like a zit or explodes like a volcano. And then you rush to try to put a clot on top of it. And when that happens, that's a heart attack or a stroke if it's happening in a carotid artery or inside the brain. And so being able to calm all of that down is a wonderful mechanism. Shouldn't have to do it. If you're doing a whole food plant-based diet, you should have a low enough C-reactive protein that colchicine isn't necessary.
Fantastic. Thank you, Kim. And I have two questions. My first one for you is, what would you like to share with our audience, both live and watching, about the journal, how they can get involved, how they can support the journal, and even connect that with Plantrician University?
Well, that's wonderful. It's a great question, and I'm hoping that people are interested in supporting. You mentioned something that I don't want anyone to gloss over. That is I'd like to say it's the only one, but there's another one here at University of Louisville, a lifestyle medicine journal that was started a few years ago, a couple years after ours. So there are at least two that I know of, but not very many, that are open access and free to the authors. So free to the authors, free to the subscribers. So it's really important to try to support it. If people have funds and they want to give to a nonprofit and direct it towards the Plantrician Project to make sure that we keep publishing, that'd be great. But the other side is to think about prevention in your particular area and how you could contribute to something successful that you're doing. And we get a lot of case reports. We get a lot of good manuscripts. Some of them are very small studies. Some of them are a single case with some incredible results. But whatever you're doing that's successful, let's write it up. And if you go on IJDRP.org, you're able to follow the submission guidelines, and we will review it. And we'll give you good objective evidence and peer review. And hopefully you'll end up with a publication that you can show and share with people. So it's an opportunity to really affect the people around you, and that's what publications do. I mean, so I like to tell my trainees that, as a clinician, if you work really hard and long, you can actually see tens of thousands of patients. If you teach, you can affect hundreds of thousands because your trainees are all going to do tens of thousands of patients. If you do research and publications, you actually can affect millions just because you're getting the word out. And this is an international journal. People are going to see it all around the world.
That's right. This is the exponential impact that comes from a life that is, serving others and multiplying that by educating others at the first level as a teacher, and secondarily through publishing data and doing studies. And that's how we can affect the culture around the world with plant-based nutrition.
Mm-hmm.
Educating more healthcare professionals, students, and residents, and publishing data that's going to reach into those places where we may not have the opportunity to speak to them.
So everybody's familiar with autocorrect. There was recently I had an autocorrect that was very insightful,
Hmm.
uh, because we've talked. I did squeeze in the evidence based on hormones, stress hormones, and animal. That's a kind of an animal rights thing. But anyway, the autocorrect when I took plant-based nutrition, it changed it to planet-based nutrition.
Hmm.
And this is something that Eat Lancet and a lot of folks are really focusing on. And I would encourage anyone who's interested in plant-based nutrition to think of it as planet-based nutrition and what we're going to do. Oh, and you made me say out loud what month it was and what year. It was March of 2020, 2003. There is a vegan calculator that I actually stuck that data in. And it'll tell you how much carbon dioxide, how many you save the planet, how much water you save the planet, and how many animal lives you saved. So I encourage everyone who's plant-based to do it, and anyone who's not plant-based, the clock's ticking. Okay, give it a try.
That's great. Thank you, Kim. And in closing, my last question for you, Kim, is after 45 years as a practicing clinician, your leadership roles and all that you've done, what are some of the, or maybe one or two of the most poignant things that you've learned along the way that you would share with our colleagues this evening?
Well, you've heard my two sort of famous quotes. One is, I don't mind dying. I just don't want it to be my fault. That means capture the evidence and do everything you can for yourself and everyone around you. Never be the burden to your kids. You spend all that money getting them through college. I have three physicians and an elite marine engineer. I mean, these are amazing kids. And why would I take away from them by not doing the best that I can for my own health? So I try to play tennis every day. I try to do a whole food plant-based diet, reduce the stress despite the fact that things come at you as chair medicine from everywhere. And you just do the best that you can to deal with it. Um, and so I would say that we have a responsibility to do that and then to share that with everyone. And it's not easy to change culture. There's so many barriers from people to that they don't want to change because of X, Y, and Z. And those X, Y, and Z are real reasons. But um, what I found is that in medicine, you get some real teachable moments. You get people who are in dire straits because of some disease. And right now, I'm not sharing any slides, but if I were, I'd share the one that I showed you at Plantrician. I keep collecting, and a lot of them came from IJDRP, but I keep collecting things, conditions where plant-based nutrition can eliminate the disease or lessen it. And right now, there's 61 of them on that slide. And this is just, why would we not do this? Why can't we convince all cardiologists where the leading cause of death of heart doctors is still heart disease? Because we know how to treat it, but we don't know how to prevent it. So we have a lot of work to do. And so I would say, my sort of top uh, messages from 45 years of academic cardiology would be that we have an opportunity going forward to change how healthcare is delivered. If the CDC says 80% of our healthcare costs are due to nutrition issues, and we know that our healthcare disparities are due to nutrition issues. This is UAB's regards trial talking about Southern diet. That's a nice way of saying soul food. That your wonderful colleague that helped with the HELP program, Columbus Batiste, and the slave food program, people don't want to hear it, but we're still eating the food that we were eating back, 200 years ago. And so I'm never fine with it. It's worse on Juneteenth because we think that we're done with slavery and we're not. And so if I had to sum up my 45 years, it's been a transition to, like I say, more attention to prevention. That's where we need to be. And that hopefully I'll continue to do that for the rest of my career.
Thank you, Kim. We're going to join you on that journey. Uh, there's no retiring in my future, and I suspect the same of yours, right? We've got a lifetime of work ahead of us.
I certainly hope so. But wouldn't it be nice to wake up one morning and everybody's gone vegan? And by the way, whole food, plant-based vegan, not junk vegan. And
Exactly.
and they're doing wonderfully, and we don't have jobs. Oh, that would be so nice.
We're working for that day. Yeah.
Absolutely.
Well, Kim, I appreciate you. Thank you for sharing your gift of time, your wisdom, your experience, your life with us. And thank you for your leadership on the journal, and mostly for your sincere friendship. I count you as one of my closest friends and love you from my heart. So thank you for being with us tonight.
The love is shared. Back at you, Scott, and thanks for all you're doing. Wouldn't be where we are without you.
Thank you. And thanks to our team tonight, and thanks to all of you for joining us. We appreciate your partnership. As Kim said, as we're working together to change this world with Planet Nutrition. And so I wish you all a beautiful evening. Enjoy your fall. Again, if you know medical school students or residents or faculty members, please send them a link for Plantrician University. It's the free platform where they can get information like this and evolve in their careers. And IJDRP.org. It's free. Send it to 5 colleagues tonight, medical school residents. And if you're inspired, send us a submission. We would love to work with you and publish your studies. So on behalf of everyone tonight, our amazing team, Kim, thank you. And God bless you all. Have a great night. Thanks for joining us.